Hello, everyone, and welcome to the Greeley Healthcare Podcast. My name is Sally Pelletier, and I serve as an advisory consultant, and I'm the Chief Credentialing Officer for the Greeley Company. We are, of course, aware that COVID-19 has caused hospitals and health systems to reevaluate several things, including their existing workforce. We know that it has caused states to suspend regulations to accommodate the demand for expanding scopes of practice, and accreditors to loosen requirements to allow for patients to have quicker access to clinical care, and that many health systems are in the midst of surge staffing. I'm here with Ann Roberts, Vice President of Medical Staff Services at Mount Sinai Health System in New York City. And in just a moment, Ann is going to share some of the valuable lessons learned by health systems in New York City who have been significantly impacted by COVID-19. First, I also want to remind our listeners that we have a variety of topics related to COVID-19 on the COVID-19 Resource Center at the Greeley Company's website. That's greeley.com, Greeley.com. And Ann, I know you're right in the heat of it there in New York City, and your time is so valuable. Thank you for being with us today.
Thank you, Sally. Unlike any other event in our professional lifetimes, the COVID-19 pandemic places unprecedented demands on the healthcare system. This mismatch between patient volume and available resources necessitates the adoption of what are known in emergency management as crisis standards of care. When hospitals hear disaster policy or crisis protocols, in the past, they've typically prepared for things like a hurricane, such as Hurricane Katrina or Sandy. Here in New York City, 9/11 challenged our hospitals. However, what you hear from everyone facing COVID-19 is that nothing of this magnitude has simply completely overwhelmed the entire system. No amount of preparing or testing your disaster policy really prepared for these types of challenges. I am really thankful to Greeley for putting this together, and I really hope that some of the lessons that we have learned here in New York City can help other hospitals where the surge hasn't hit yet to prepare.
Well, and we're thankful that you're willing to share your knowledge with us. We are hearing of hospitals shifting surgeons to partner in medicine and other implementation of various care models in order to tackle COVID-19. Can you share your experience in regard to what you're seeing as it relates to the shifting of resources?
Absolutely. COVID-19 is an infectious disease that attacks the respiratory system and can lead to acute respiratory failure. So as such, your emergency medicine teams, hospitalists, and critical care teams are the primary providers that are caring for these patients. When hospitals cancel their elective surgical procedures and other elective services, you have to think critically about how to best utilize the skills from those teams who now have some downtime. For example, when surgery centers are forced to close, the anesthesiologists and the CRNAs have critical care training, and they're highly skilled at airway management. So they could easily transition over to the hospital and be incorporated into your medical teams to help care for these patients. For other members of the clinical staff, you have to focus on how to best align them and incorporate them into your current medical care team models. Your chairs of surgery could consider partnering closely with the chairs of medicine to build care teams to deploy to the different sites. As this is a respiratory disease, partnering the surgeons closely with critical care physicians and hospitalists and your emergency medicine teams can help provide the support that they need to handle the influx of patients. You can also utilize them in lower acuity settings to test and screen patients, function as PAs. We've also seen some CRNAs that can help fill in as critical care nurses. Like everything that we've talked about, you have to really assess what works best for your organization. And this doesn't always just apply to your medical or your clinical teams. A lot of staff across healthcare systems today have been displaced. So it's a great idea to be able to really assess the various skill sets for all hospital staff and identify how they can best be used to support the current environment. They may be assigned to different roles that they've never worked in before. Temporarily, you have to be creative.
Very interesting. I know that advanced practice professionals such as PAs, physician assistants, and our advanced practice registered nurses, they certainly play a key role as critical members of the healthcare team. However, in sort of the normal day-to-day, they're often not practicing at the top of their license in hospitals. Have you expanded the scope of these advanced practice professionals? And if so, what did that look like?
Certainly. So the waivers that are in place at the federal and state level have really helped to ensure that we have better coverage. Our APPs are critical staffing right now. Organizations see a high demand for CRNAs, inpatient emergency medicine experienced PAs, and critical care teamed NPs, for example. These are highly skilled clinicians that have the ability to care for these patients. They're incorporated into our care team models. So it's not really about expanding their role. It's about how best do they fit into the care team models, and how can we maximize their expertise to support the current model. Our ability to now accept providers who are licensed in other states have, of course, also helped really staff these key roles. I would say organizations really need to weigh this carefully and determine what's best for their organization. Do you currently have countersignature requirements? Do you have different supervision requirements based on individual providers' skill levels? You don't want to have to remove these requirements without first doing a thorough assessment of what is best for patients and what is best for the organization. You have to ask what's doable and sustainable under the current circumstances. When looking at all of the regulatory requirements and asking this question, it also applies to administrative challenges. As an MSP or an HR professional, an attorney, etc., we can get really hung up on regulatory requirements because that's our job. That's what we do. We ensure compliance at all times. Joint Commission standards state that in a disaster, you must verify a provider's ID in person. When the standard was written, I'm quite certain that no one pictured having to worry about the staff verifying the person's ID in person, being at risk of being exposed to a potentially deadly virus. As such, these days, technology can be our best friend. As an attorney, I'm trained to weigh all options and argue both sides of the case. What are the benefits versus the cons of every situation or every scenario? It's about weighing the risks and choosing the best option for your organization, for your patients, for your care team members. And that's why a lot of attorneys go into risk management, because you have to weigh all of your options. For this particular situation, the way that we did that is we were first focused on the regulatory requirement that you do the ID verification in person. And like everything in today's environment, you circle back and you focus on what is the standard of care right now? What is best for the patients and what is best for the care team? So when you break those questions down, you know right away, it is of course still best for patient care that we verify a provider's identity. That of course isn't a question. It is not, however, best for administrative team members to do this simple task in person and risk potential exposure. Our clinical teams on the ground, they're not going to have time to do this when new providers arrive ready to work. It's a very busy environment, and we want to be able to make it as smooth as possible to get these providers working and seeing patients as soon as possible. So it really needs to be done ahead of time. So collectively, I partnered with our HR leaders and our regulatory compliance leaders. We made an informed decision, and we all agreed that the best resolution to this was to use FaceTime. You know, physicians have been using telemedicine technology for quite some time. There's no reason we shouldn't be able to use similar technology during this time to help protect our workforce. So those are some examples of the way that it's really impacted all areas of the health system.
Excellent, excellent. And that makes just so much sense. So thank you for sharing that. I'm going to go on to the issue of current competency. So we know that there are physicians and other practitioners who have been out of the workforce for a period of time, and yet they really want to offer their services, I guess I should say. They're wanting to volunteer, assist wherever they can. What about practitioners who have been out of the workforce for a period of time? They don't have evidence of current competence. Is there a way that they can be used clinically at this time and re-enter the field of medicine?
Absolutely. So like with everything that systems are faced with right now, you really have to weigh the pros and cons of every situation carefully. Even when you're under time constraints and you have high patient census needs, you still have to go through that evaluation. So With anyone in any profession that steps out of the workforce for a period of time, you don't just suddenly lose your knowledge and your skills. You simply may need a refresher and to catch up on what's changed since you've been out. For those re-entering the workforce, you would of course want to partner them closely with the other members of the care team to determine what clinical assignments are most appropriate for that individual based on their education, training, and their existing skill levels. For some of those who may not necessarily be needed in critical care, the ED, or medicine units, such as other subspecialists or those who may have been out of the workforce for quite some time, there are also the surge or the overflow areas where they're screening and testing and caring for lower acuity patients, more of an outpatient care type setting where their skills can still be very useful. You also have to take into consideration and be sensitive to, as with any of your volunteers, the risk factors for anyone who may be a vulnerable patient themselves in that age group or who have underlying issues. They might be better suited to help in administrative roles like screening volunteers or locum tenens providers, helping with scheduling or advising. They can do telemedicine consults if they're qualified. So there's a lot of different ways that healthcare providers can help and get involved.
Thank you. How about those that are in the community? So how do you suggest engaging community and network providers who may not routinely provide care in the hospital setting? What do you think about those folks?
That is a great question, Sally. Most organizations, especially large healthcare systems, have a great group and a very large group of community and or network providers, most of whom are already credentialed by your organization. Because they've been enrolling in your plans and you've done provider enrollment and things like that. And some may even be members of your medical staff who may not currently hold clinical privileges. In my mind, this really should be your first group of providers that you want to be able to reach out to and seek to beef up your current staffing models, most of whom are willing to come and help in any way that they can if they're not otherwise committed. Absolutely a great idea to partner with these individuals, these physicians, these clinicians, and make them members of your care team. Also, if you have multiple locations, many of them may live closer to those facilities and are willing to be assigned to help at the nearest location.
Great point. Great point. I know you've already covered some operational issues, but particularly for our medical services professionals, you know how they like to get into the operations. So I'd like to focus a little bit more on operations. What are some of the challenges you've faced, and what can others do to be more proactive and be as prepared as they possibly can?
Well, I would say changing the way we do business to align with today's environment, because today's environment is much different than what we are used to as administrative teams, where we normally work Monday through Friday, 8 to 5, maybe occasional late meetings here and there. But clinicians work 24 hours a day, 7 days a week. So we have to really adjust because our normal 8 to 5 model just doesn't work in today's environment. We needed to realize that we had to adapt to align with the care teams to the extent possible. So therefore, I restructured our teams into a similar model. Staff now work in shifts. Our administrative, medical staff, HR, orientation teams are working in shifts to ensure that we have sufficient coverage to support the ongoing needs of our frontline staff. We have been working to transition to shift work so that we have coverage to be able to address any issues that arise from 7 a.m. to 11 p.m., 7 days a week. As you know, when you're in a disaster mode and you have hundreds of volunteers wanting to assist, and you may be working with people coming from outside of your current location, they're traveling at all hours of the night. So you have to make sure that you have the logistical steps in place to ensure it's a smooth process. Our evening shifts are working hard to ensure that the scheduling needs for the next day are met. We will also continue to evaluate if there are things that are coming in overnight that might require us to seek volunteers from our team to work an overnight shift. It hasn't come to that yet, but we're definitely prepared if it does. We've implemented handoff procedures to make sure that when one care team member or when one member of our team is about to sign off from their shift, they can easily and properly hand off all outstanding items to the next person. So another takeaway from our care teams are handoff procedures. Same way our clinical teams have transitioned to incorporate care teams, we have also had to break our team apart to support the current needs. And some of these teams have members from across the organization involved. So on the clinical side, as we talked about, our surgeons are partnering with our medicine physicians. We also have the credentialing and privileging team, medical staff services, and HR. These teams must partner very closely, making sure clinicians are properly screened, credentialed, and privileged. This also includes a team of physicians and advanced practice leaders who are evaluating all of the different candidates coming in, whether they're volunteers or locums, and identifying if they're qualified for the roles which we have a need for on our clinical teams right now. We are very fortunate that during this type of disaster, our teams have the ability to work remotely, and we have the resources to where even when onboarding someone rapidly, we can still do a great deal of credentialing in advance, since most everything is available electronically, as far as sanctions checks, license verifications, certification verifications. We're still doing background checks because we're fortunate enough to have the staffing and resources to be able to do that. If we don't have time to do the background check, then we still do it upon arrival, and then we monitor it very closely, over the next 3 or 4 days until we get the results. And so for organizations with small medical staff offices, especially, or HR teams, I would really recommend ensuring that you have sufficient backup. Training guides should be developed in advance on how to verify essential items. What's the OIG website? And what are the state licensing websites? And how do you get there? Because you may end up having to utilize some of your HR partners who can help fill in when you're starting to get a surge of providers coming in. We also have an onboarding team. This team works to ensure that that the providers have everything they need to get started, including getting them access across the system to our electronic health record system, identifying what orientation they need, such as perhaps an EPIC refresher class, badges, hotels, travel. Our onboarding team is multidisciplinary, and they're working together to ensure that this goes very smoothly. We also then have a deployment team. We have a team of physician leaders who make clinical assignments for all of the providers that have been cleared by the medical staff office or our HR team to start. They plug them into the care team, these providers, at the location where they feel the individual is best suited based on many factors, such as the level of need at that location and the individual's education, competency, and also their demographics. The rest of the deployment team, which is a mix of HR, medical staff services, occupational or employee health, and others, ensure that they're set up, introduce the staff at the facility where they'll be deployed to so that when they get on site, they can have proper handoff. It's really about doing what works best for your organization, trying to anticipate all of the nuances of getting a person onboarded and figuring out the best way to do that as quickly as possible.
And thank you for that detail and your final statement there. My takeaway from that is, when you said it's really about what works best for your organization, trying to anticipate and figuring how to do onboarding as quickly as possible. I suspect there's going to be a lot of takeaways from this that will probably change credentialing and privileging going forward, because isn't that what we've wanted to accomplish for so long? And of course, this situation won't last forever. But that's what struck me about what you just said. What about the command center itself? What can you tell us about what has worked well there or particular lessons learned?
Absolutely. I think most people who work in a hospital system that's ever had to handle a disaster recognizes the importance of having a well-functioning command center. And with a command center, you typically have your executive leaders from each of the different areas really highly focused and partnering together to address issues and address them quickly. I'd say that the things that stand out the most to me are backups, handoffs, and cut out the red tape. For backups, for all key positions, you want to have 3 to 4 layers of individuals for all key positions to make sure that they're cross-trained, and it is important for many reasons. As I mentioned earlier, we've had to adapt our normal way of doing business to really having the business side of the house in sync with our clinical teams. It's important to be rested as a key decision maker. As it's so fast-paced, you need a backup so that you can hand off to them. Some of my best ideas tend to come to me late at night when I'm finally able to slow down at the end of the day and take a deep breath. So it's very important to be able to hand off and take a break. Also, people are getting sick or their families are getting sick. You have to be prepared for every position to need a backup and work in shifts with great handoff communication, just like the care team does. Senior leadership teams also work hand in hand on everything. Everyone at the virtual table are typically key decision makers, and we all have the same goals and the vision of where we're heading and what needs to get done. There simply is no time right now for red tape. If issues arise, the key decision makers can collectively discuss, identify the best approach so that they are making informed decisions and keep things moving. What has made this easier for me anyway, is that we have amazing leaders. Everyone is in sync and have the same understanding of what the mission is, doing everything we can on our end to help the frontline staff focus on taking care of patients. The teamwork has been phenomenal, especially between the medical staff and our administrative teams. Great partnerships, and it's extremely important.
And that's phenomenal. And as you know, I know a few members of your administrative team as well as your medical staff leaders, and doesn't surprise me that the teamwork has been phenomenal. So great news there. Thanks for sharing that. I would suspect you also have had to use some locum tenens, and what are your recommendations there for using certain agencies, or what have been some challenges you've seen with utilizing locums? Can you share some of that with us?
Sure. I'd say these agencies should really become your partners in this fight as well. We all have the same goal: ensure that we have the right number of providers to care for the patients, and ensure that those providers have the proper education and training. If you can't fill the need using existing staff or volunteer staff, then you should partner closely with these agencies. Another way that locum agencies can be good partners, all providers must be cleared by the medical staff office or by human resources. So while it's really nice for these agencies to reach out and offer assistance, it can become a little bit distracting and a little bit of extra noise when these agencies are reaching out to every department, reaching out to executives directly, reaching out to physicians directly. These individuals need to be focused on leading and taking care of patients. So it's really best if the agencies will reach directly out to the medical staff office or the HR office and focus their requests there. So that, one, it can be handled promptly and you're immediately with the right connection. It's really important that your organization also provide very clear directives to the agencies in regards to what you're looking for in order to drill down and have the right providers. Are you looking for someone who can dedicate an entire month so that they can be assigned to a care team? Are you looking for an individual who can just fill in for certain nights or weekends or to plug a hole in one of your shifts? Do you want family medicine trained hospitalists or ED attendings, or only internal medicine trained providers or critical care or emergency medicine trained providers? What hours will they be working? So you have to work through all of the logistics and be able to give them some clear guidance, and that will really help. Sometimes it's not easy to predict schedules, of course, and things are constantly changing. So you need these partners in the agencies who are flexible and are extremely organized. Some of the challenges that I've heard of, in working with my partners here in New York and the other large healthcare systems, we've all talked and we share information. And if the agency isn't as organized as they should be, or they're not giving clear directions to their staff, then it can cause more chaos than it can be worth. And so you really have to partner closely with the agencies, make sure you are giving them clear directions, making sure the agencies are giving the providers clear directions, and that you have some connection before they get here so they are fully prepared when they come on site. You also want to be able to prepare staff for what they will face when they arrive and ensuring they understand what the crisis standards of care are. Our Deputy Chief Medical Officer, Dr. Mark Knapp, framed this very well when he said, frankly, this is not a healthcare assignment. It's a humanitarian mission.
Wow. That's powerful right there. I would imagine with the just the sheer numbers of the locums that are coming into your facility now, that's probably definitely not the norm. And so just tracking their schedules, what advice can you give? How did you handle that piece, which I am sure is, again, a lot more volume than you're probably typically having to manage?
Absolutely. While we, of course, have 8 hospitals, we have a wonderful medical staff, we have a large network of providers, we have had to use some agencies. And normally with agencies, you send out individual timesheets and you're tracking their schedules. You reconcile those against your own records, and then you send out an invoice. It's manageable if you don't have too many of them. But if you're starting to funnel in agency staff from a lot of various agencies, when you're needing to, you really need a scheduling tool to help monitor all of this. I use rotating residents coming from various medical schools who work different shifts and different schedules as an example. I would partner with your GME team and ask what scheduling tool they are using, such as Amion or New Innovations, and see if you're able to load these providers, directly from your credentialing database into that scheduling tool to help track these individual schedules. It makes it a little bit more manageable if you are in need of using a lot of agency staff. Then you can better reconcile their time with the various agencies.
Makes total sense. Automate it as much as you can, utilizing what you have. How about the screening for clinicians? What do you recommend in regards to handling the COVID-19 screening?
Sure. The screening providers prior to them arriving at your organization and seeing patients, of course, is extremely important. And it really kind of varies depending on the type of provider. So if you're using agency personnel for any of your staffing needs, what you really want to do is you want to negotiate and when you're negotiating these contracts, you also want to get a copy of their credentialing policy and evaluate how they're screening their staff from that perspective. And you also want a copy of their current COVID-19 screening protocols to ensure that they are properly screening their staff prior to their arrival every time they're taking a shift. So whether that is they're on for a weekend, they leave for a week, they come back, they need to be screened each time. We also have really beefed up our occupational or employee health offices because those providers are working around the clock to ensure they have sufficient staff to screen providers who are either coming in or who may be displaying symptoms. And then you have your voluntary staff or staff that are coming in as a per diem temp employment assignment. We have, and what's worked well with us is our physicians are closely screening these providers, looking at their CVs, identifying their qualifications. And at that time, they're also asking some specific screening questions during those conversations, such as, do they have any underlying illnesses? So are they really fit for duty for the type of assignments that we have available? Or could we, like we mentioned earlier, utilize them in some other role?
In closing, I know, this has been a very stressful time for physicians and other practitioners, and they were already experiencing burnout. We know that our physicians have, really been burnt out for a number of years now, and this on top of it. What are you doing specifically to support the caregivers?
Sally, I am humbled every day by what our frontline staff are faced with across the country. The challenges of dealing with extremely high patient loads, having extremely difficult conversations with patients and their families, things like coordinating FaceTime chats so they can say their last goodbyes, dealing with higher mortality rates than they're used to dealing. It can, of course, be overwhelming. You have to ensure that you're carefully considering schedules as well. Are they working straight 12-hour shifts? Would an 8-hour shift be more feasible in today's environment? Do you schedule them for 3 days on and 1 day off, or 4 days on and 2 days off? You have to, like everything else, weigh the pros and cons and what is best for the patients, but also what's best for your care team members. You also need to have counselors, resources, pastoral care ready to support all of your staff and your patients and their families. You need to have options for these to be done remotely via telemedicine at all hours. And one of the things that a lot of people have talked about is when somebody gets off their shift, should it be required that they debrief for a little bit with someone? But at a minimum, at least have those options available for them so they can debrief at the end of their shifts. This doesn't just apply to frontline staff. Leaders are working around the clock to support all of the needs. There can be a lot of stress and pressure involved for the administrative leaders as well. These services need to be available to all members of the team, as you will experience burnout in these areas if you don't have a backup and support resources. High functioning leaders are typically going at rapid fire pace, answering thousands of emails a day while also in meetings, managing staff, and ensuring balance. It can be really hard to shut your brain down at the end of the day as you're still going back through your long checklist in your mind, trying to make sure that all the I's were dotted, the T's were crossed, that all the shifts were covered, and that your teams are running smoothly. So personally, I have started trying to incorporate small breaks throughout the day, even if it's just a 10-minute reset, practice a little mindfulness or meditation, something to help unwind. So making sure that you are taking care of your personal, emotional health as well, and having a fine balance, and making sure your organization is supporting these initiatives and providing the resources is also a critical piece to this.
Well, thank you, Anne. And I know personally that you are one of those high-functioning and very, a leader that's in a very stressful situation. And I know you've been working around the clock. And we really thank you for your insight today. I wish you continued well-being, both mentally and physically, as well to all of your colleagues there at Mount Sinai. And I want to thank everyone for listening today. If you'd like to hear other podcasts related to COVID-19 and what our consultants recommend on a variety of topics, please go visit our website at greeley.com. And again, Greeley is spelled Greeley.com. And we thank you for your time.